Good day, my dear colleagues. I am Dr.K Gireesh, physician, neurophysician, and neurosurgeon. This is the RNA series. Questions in neurology and neurosurgery with answers by me, and that's Dr. Gireesh. This, in fact, is to benefit the practitioners of neuroscience and the medical field for a lifelong learning and also for public awareness. In this series, RNA, the question that I'm addressing is, what are the features of Binswanger's disease or the subcortical leukoencephalopathy? Well, by definition, Binswanger's disease is a form of subcortical vascular dementia caused by chronic small vessel ischemic disease, leading to diffuse white matter damage. This was first described by Otto Binswanger in 1894. Now, Otto Ludwig Binswanger is a German psychiatrist and neurologist. The pathophysiology of this disease, the chronic hypertension and vascular risk factors lead to lipohyalinosis of the penetrating arteries, which reduce the deep white matter perfusion and leads to demyelination with the lacunar infarcts, which leads to subcortical cognitive impairment. It primarily affects the periventricular white matter, the deep white matter, and the basal ganglia. Now, the risk factors for this are a long-standing hypertension, most important, diabetes mellitus, smoking, hyperlipidemia, advanced age. These are the risk factors. The clinical features, the cognitive changes include executive dysfunction, slow processing speed, impaired attention, subcortical dementia pattern. And the motor features are the gait disturbance, the magnetic gait, lower body Parkinsonism, pseudobulbar palsy, behavioral symptoms, apathy, depression, emotional lability. This is a stepwise or a gradually progressive decline. The MRI findings are the diffuse periventricular white matter hyperintensity, lacunar infarcts multiple, enlarged ventricles secondary to white matter loss, and no predominant cortical atrophy, unlike in Alzheimer's. So it's primary clinical plus radiological is the diagnosis. Subcortical cognitive syndrome, imaging evidence of diffuse white matter disease, and the presence of vascular risk factors. The differential diagnosis include the key differentiators from Alzheimer's disease, early memory loss, hippocampal atrophy, cadazal, young age migraine family history, then multiple sclerosis, normal pressure hydrocephalus. So these are all some of the differential diagnoses which is got to think of. The treatment, no reversal is possible. You have to focus on the vascular control, strict blood pressure control, diabetes management, and the platelets if indicated. Statins can be given, provided with the cholesterol, and cognitive rehabilitation, physical therapy for the gait. Prognosis. What about a prognosis of Binswanger's disease or subcortical leukoencephalopathy? Gradual cognitive decline, a functional dependence over the years, and prevention of the progression depends on the vascular risk control. Very important. If an elderly hypertensive patient presents with executive dysfunction more than the memory loss, gait disturbance, MRI showing diffuse periventricular white matter changes, think of Binswanger's disease rather than pure Alzheimer's. And various articles are there by O'Brien et al. 2003 in Lancet Neurology, Pantoni et al. In the Lancet 2010, Roman GC, Vascular Dementia Criteria in Neurology 1993, and several other publications are there of recent. That's indeed, dear colleagues, on briefly on the features of Binswanger's disease or subcortical leukoencephalopathy. Thank you very much.